So oral loading of antihypertensive agent has been used successfully in patients with hypertensive crisis when urgent but no immediate reduction of BP is indicated. First one, oral clonidine loading. Oral clonidine loading. See, this has been used successfully in patients with hypertensive crisis when urgent but not immediate reaction. That means it's urgent. We can use some oral medications rather than IV to control the BP, but it's not an emergency, like it's not immediate reduction of BP is indicated, but we have to reduce the BP. So such things we use oral clonidine loading is achieved by using initial dose of 0.2 milligram per oral. The dose is 0.2 milligram per oral followed by 0.1 milligram per oral Q1H to a total dose of 0.7 milligram, or a reduction in diastolic blood pressure of or diastolic blood pressure reduction more than 20 millimeter of Hg. So clonidine, as we know, is a centrally acting adrenergic agonist. So the drug of choice, the drug dose is 0.2 milligram per oral. That is 200 microgram followed by 100 microgram per oral. Okay, every 1 hour. The total dosing is more than or is about 0.7 milligram, and or a diastolic blood pressure in reduction in more than 20. See, the BP should be checked at 15 minutes interval over the first hour. So the BP should be monitored. (15 minutes interval over first hour, 30 minutes interval over the second hours. And after 6 hours, a diuretic can be added and a 8-hour clonidine dosing interval can be begun. And after 6 hours, a diuretic can be added and an 8-hour clonidine dosing interval can be begun. Sedative side effects are significant. So first what we do is we first give 200 microgram followed by 100 microgram, a total dosing of 700 microgram, or a reduction in BP more than 20 millimeter of Hg. BP should be checked every 15 minutes over the first 1 hour, next 30 minutes interval over the second hour, and after 6 hours a diuretic can be added and your 8-hour clonidine dosing interval can be begun. Next is sublingual nifedipine. Another drug is sublingual nifedipine. It's a calcium channel blocker. It's a long acting. Sublingual nifedipine. It has an onset of action within 30 minutes. The onset is 30 minutes, but can produce wide fluctuations and excessive reduction in BP. Because of the potential for adverse cardiovascular events, stroke or MI, sublingual nifedipine should be avoided in acute management of elevated BP. So avoid in acute management of elevated BP. Side effects include facial flushing and postural hypotensions. Side effects include facial flushing and postural hypotension. that's it. Now we will consider some, we'll look into some special considerations. For the first one, the hypertensive crisis. Among hypertensive crises, in hypertensive emergency, the control of acute or ongoing end organ damage is more important than the absolute level of BP. BP control with a rapid acting parenteral agent should be accomplished as soon as possible, that is within 1 hour, to reduce the chance of permanent organ dysfunction and death. A reasonable goal is to 20 to 25% reduction of mean arterial pressure or reduction of diastolic blood pressure to 100 to 110 over a period of minute to hours. So the first intention is within 1 hour in hypertensive emergency, within 1 hour we should reduce the BP, that is 20 to 25% reduction of mean arterial pressure or you can reduction in diastolic blood pressure to 110 like 110 millimeter of Hg. This is it. So it should be done within minutes to hours. A precipitous fall in BP may occur in patients who are elderly, volume depleted, or receiving other antihypertensive agents. BP control in hypertensive urgency can be accomplished more slowly. The initial goal of therapy in urgency should be to achieve a diastolic blood pressure of 100 to 110. Excessive or rapid reduction in BP should be avoided to minimize the risk of cerebral hypoperfusion or coronary insufficiency. So when you are reducing the BP rapidly, rapid reduction, it can lead to cerebral hypoperfusion and coronary insufficiency. Okay, remember this. Next is you see, next comes normal BP can be attained gradually over several days as tolerated by the individual patients. So aortic dissection, next consideration is aortic dissection. When considering the aortic dissection, acute proximal aortic dissection type A is a surgical emergency, whereas uncomplicated distal dissection type B can be treated successfully with medical therapy alone. So first you have to see the types of dissection. So these are a type of aortic dissection. The type 1 originates in the ascending aorta, propagate at least to the arch of aorta and often beyond distally. So it propagate beyond distally also. It's propagated beyond distally also, okay, from the arch of aorta to distally also. Next is type 2, that originate in and is confined to the ascending aorta. The type 2 is confined only to the ascending aorta. Next is type 3. Type 3 originates in the descending aorta and extends distally down the aorta or rarely retrograde into aortic arch, ascending aorta. So it is in the descending aorta, and also it sometimes distally down the aorta, rarely it retrograde to the arch. Okay, that is about the type 3. Among the type A includes type 1 and type 2. Type 3 is a type B. So type A means all dissections involving ascending aorta regardless of site of origin. Type B is all dissection not involving ascending aorta. That type A, that is type A means proximal to the arch origin, is a surgical emergency because it propagates arch as well as distally, so surgical emergency. Whereas uncomplicated distal, that is type B. Type B is without arch of aorta or proximal arch of aorta. It can be treated successfully with with medical therapy. All patients, including those treated surgically, require acute and chronic antihypertensive therapy to provide initial stabilization and to prevent complications. Example, aortic rupture and continued dissections. Medical therapy of chronic stable aortic dissection should seek to maintain systolic blood pressure at or below 130/140. So what medical therapy is aiming is, what medical therapy aims? Medical treatment aims at maintaining the systolic blood pressure, to maintain the systolic blood pressure below 130/140 if tolerated. Antihypertensive agents with a negative inotropic property, including calcium channel blockers, beta-adrenergic blockers, methyl dopa, clonidine, reserpine, are preferred for the management of post-acute phase. So what all drugs we use here? We use here is a negative inotropic effect, the calcium channel blockers. We use beta blockers. We use alpha methyl dopa. We use a centrally acting adrenergic, that is clonidine. We use a reserpine for the post-acute phase. Okay. The sodium nitroprusside. You remember that the sodium nitroprusside we use in our hypertensive emergency. Sodium nitroprusside is considered the initial drug of choice. It's an initial drug of choice. Because of the predictability of response and absence of tachyphylaxis. The dose should be titrated to achieve a systolic blood pressure of 100 to 120 mm of Hg over the lowest possible BP that permits adequate organ perfusion. Nitroprusside alone causes an increased left ventricular contractility and subsequent arterial shearing force. So the main aim is to maintain systolic BP of 100 to 120, and it can the nitroprusside can increase left ventricular contractility. And subsequent arterial shearing force. Okay. You see, which contribute to ongoing intimal dissection. Thus, when we told that a nitroprusside can increase LV contractility and subsequent arterial shearing force. So sometimes it can go for subsequent arterial shearing force. It can contribute to ongoing intimal dissections. Thus, when using sodium nitroprusside, adequate simultaneous beta-adrenergic antagonism therapy is essential, regardless of whether systolic hypertension is present or not. That's why, because this arterial shearing force, so that we use here for the prevention, we use beta-adrenergic blockers. Beta blockers is essential. Regardless of whether systolic hypertension is present. Traditionally, propranolol has been recommended. Esmolol, a cardioselective intravenous beta-adrenergic antagonist with very short duration of action, may be preferable, especially in patients with relative contraindications to beta agonist. If esmolol is tolerated, a longer-acting beta-adrenergic antagonist should be used. Next, IV labetalol. This is in case of dissection. Okay, dissection has been used successfully as a single agent in treatment of acute aortic dissections. Treatment of acute aortic dissection. Labetalol produces a dose-related decrease in BP and lower contractility. It has the advantage of allowing for oral administration after the acute stage of dissection has been managed successfully. So next comes the another topic, that is an elderly hypertensive patient. It is age more than 60. That is age more than 60, elderly hypertensive patients. So they are generally characterized by increased vascular resistance, decreased plasma renin activity, and greater LVH than in younger patients. Often, elderly hypertensive patients have coexisting medical problems that must be considered when initiating antihypertensive therapy. The drug dose should be increased slowly to avoid adverse effect and hypotensions. So in these patients, vascular resistance is probably high. Vascular resistance is high. There will be decreased plasma renin activity. There will be greater LVH compared to young. The drug dose should be increased slowly. Okay, that is very important. Diuretics as initial therapy have been shown to decrease the incidence of stroke, fatal MI, overall mortality in this age group. So the studies have shown that the recent studies showed that diuretics as initial therapy have been shown to decrease the incidence of stroke, MI, and overall mortality. The calcium channel blockers decrease vascular resistance. And have no adverse effect on lipid levels like diuretics, especially thiazide-diuretics, hyperuricemia, lipid derangement, hyperglycemia, all those things can occur. There also, this CCB are also good choice for elderly patients. AC inhibitors and ARB may be effective in this agents in this population also. So we can also use AC inhibitors and ARBs may be effective. This is the elderly patient. Another subclass is a patient who is elderly as well as he is having is obese. Obese hypertensive patient. In obese hypertensive patient, it is characterized by more modest elevation in vascular resistance, high cardiac output, expanded intravascular volume, and lower plasma renin activity at any given level of arterial pressure. Weight reduction is the primary goal of therapy and is effective in reducing BP and causing regression of LVH. So in these patients, you see elevation. In this patient, there will be elevated vascular resistance. Next, they will be having high cardiac output. They will be having expanded intravascular volume. And they are having a lower plasma renin activity, plasma renin activity at any level of arterial pressure, because usually renin activation occurs when there is hypoperfusion. In response to that, renin activation occurs, production occurs. So that's about here the main treatment is weight reduction, only the main treatment, so that can reverse hypertension. Also drugs like all others can be used. Next comes the subtype, that is diabetic patients. Diabetic patients with systemic hypertension. diabetic patient with systemic hypertension, what we do? Uh, Diabetic patient with nephropathy may have significant proteinuria and renal insufficiency. Diabetic patients with a nephropathy or a renal insufficiency. Management. Control of BP is the most important intervention shown to slow loss of renal functions. So, in such patients, ACE inhibitors should be used as first line therapy. It should be first line in ACE inhibitors. In nephropathy patients, significant proteinuria. Because why ACE inhibitors as first line? Because they have been shown to decrease proteinuria and to slow progression of loss of renal function independent of their antihypertensive effect. So, this ACE inhibitor decreases proteinuria. So, in a diabetic patient who is having a significant proteinuria, we use ACE inhibitors as the first line therapy. It reduces the proteinuria independent of their antihypertensive effect. ACE inhibitor may also be beneficial in reducing the rate of death, MI, stroke. So, it reduces rate of death due to MI, stroke in diabetic who have cardiovascular risk factor but lack left ventricular dysfunction. Hyperkalemia is a common side effect in diabetic patient treated with ACE inhibitors, especially in those with moderate to severe impairment of their GFR. So remember one thing, hyperkalemia, that is the potassium level increases. Hyperkalemia is a common side effect. It's a common side effect in especially in diabetic patients. Treated with ACE inhibitors. Who? In those with this severe GFR impairment. Receptor blockers, ARBs, are also effective antihypertensive agent and have been shown to slow the rate of progression to end-stage renal disease, thus supporting a renal protective effect. Similar to these ACE inhibitors, ARB is also good. Okay, ARB is also good. It's a renal protective effect. Okay, next is third type. Third type is the patient with chronic renal failure or insufficiency. Okay, patient with chronic renal insufficiency. What we do here? If a patient with chronic renal insufficiency have hypertension, that usually is partially volume depleted. Retention of sodium and water exacerbate the existing hypertension, and diuretics are important in management of these patients. So you see that the retention of sodium and water exacerbate the existing hypertensive state. So you use diuretics which are important drug in the management of this problem. When estimated GFR is less than 30 to 35 ml. So if you see that GFR is less than 30 to 35 ml per minute per 1.73 meter square. So in such case we use a loop diuretics like furosemide, the most effective class, loop diuretics. In presence of proteinuria, if a proteinuria present in these patient, if proteinuria present, then you can use ACE inhibitors Also ARBs should be considered because high urinary excretion of protein is associated with a more rapid decline in GFR regardless of cause of renal insufficiency. Next is another case of a patient, fourth one, a hypertensive patient with left ventricular hypertrophy. It's another case, a hypertensive patient with a left ventricular hypertrophy. See, these patients are increased risk of a sudden death due to MI. With MI and all cause mortality. Although there is no direct evidence, regression of LVH could be expected to reduce the risk. So how to reduce the regression? We can use the therapy as ACE inhibitors. ACE inhibitors appears to have greater effect on regression. So it regresses LVH. Okay. Next comes a hypertensive patient. A hypertensive patient, there is a systemic hypertensive patient with coronary artery disease. A systemic hypertensive patient with coronary artery disease. What all drug do we prefer? These patients are increased risk of unstable angina and myocardial infarction. Remember, so we use a beta adrenergic antagonist as the first line. There is beta blockers is the first line in these patients because they can decrease cardiac mortality and subsequent reinfarction in the setting of acute MI and can decrease progression to MI in those who present with unstable angina. So it is a cardiac mortality, the remodeling capacity in heart failure also there. So you see, beta adrenergic antagonists also have a role in secondary prevention of cardiac events and in increasing long-term survival after MI. Care should be exercised in those with cardiac conduction system disease. AC inhibitors are beneficial in patients with CAD and decrease mortality in individuals who present with acute MI, especially those with LV dysfunction. So two drugs, beta blockers are the first line, then AC inhibitors also used especially in those with LV dysfunctions. In these patients we can use AC inhibitors because this beta blockers reduces cardiac mortality. Then another case is a patient. The patient is a systemic hypertensive patient with heart failure. Symptoms of heart failure, you know, basal crux, elevated GP, S3 galopridom, like that, dyspnea. So these patients is a risk for progressive left ventricular dilatation and sudden death. So remember that these patients' risk is progressive left ventricular dilatation and sudden death. In this population, AC inhibitors decreases mortalities. AC inhibitor decreases mortality. And in the setting of acute MI, they decrease the risk of recurrent MI. Also reduces the risk of recurrent MI. They also reduces the risk of recurrent MI. Also hospitalization for HF. So that's all the main uses of AC inhibitors in heart failure patients with hypertension. In patients who are unable to tolerate AC inhibitors, we can use ARBs also. So where all we discuss ARBs, we discuss ARBs in CKD patients, renal insufficiency, in a diabetic patients who is having a proteinuria. Now in heart failure patients, we are also using this one. Also in AC inhibitors in hypertensive with CAD. So nitrates and hydralazines, very important. Nitrates and hydralazines. Nitrates and hydralazine Also decrease mortality in patients with heart failure irrespective of hypertensions. But hydralazine can cause reflex tachycardia and worsen ischemia in patients with unstable coronary syndrome and should be used with caution. So one problem with hydralazine is reflex tachycardia, so it be used with caution because it can cause insufficiency, worsening ischemia. Non-hydropyridine calcium channel antagonists should generally be avoided in patients in whom negative inotropic effect would adversely affect their status. So you better avoid non-dihydropyridines calcium channel blockers due to this negative inotropic effect. Next comes the another case conditions called pregnancy hypertension. Pregnant hypertensive patients. So there is a concern for potential maternal and fetal morbidity and mortality associated with elevated BP, and the clinical syndrome of preeclampsia and eclampsia, the possibility of teratogenic or other adverse effect. So first we should classify the pregnancy hypertension classification. Preeclampsia to eclampsia. So it's the American College of Obstetricians and Gynecology classifications. Preeclampsia, eclampsia. So in preeclampsia, there is a new onset hypertension after 20 weeks of gestations, 20 weeks of gestation with proteinuria. We diagnose it as preeclampsia. Next, eclampsia, elevated systolic blood pressure more than or equal to 140 or diastolic blood pressure more than 90 on 2 occasions at least 4 hours apart, or one-time measurement of systolic BP more than 160 or diastolic BP more than 110 qualifies as hypertension. Systolic blood pressure more than or equal to 140 or diastolic blood pressure more than or equal to 90 on 2 occasions 4 hours apart, or a single reading of systolic blood pressure more than or equal to 160 or a diastolic blood pressure more than or equal to 110. This is a two occasion 4 hours apart. Next, if no proteinuria is present, then hypertension along with one of the following qualifies. Platelet, if no proteinuria present, platelet less than 1 lakh. So platelet less than 1 lakh, creatinine more than 1.1, liver transaminase twice normal, pulmonary edema, or cerebral or visual symptoms. Cerebral or visual symptoms. Eclampsia encompasses these parameters in addition to generalized seizures. So these are preeclampsia conditions. If there is a generalized seizure, we give them a topic of eclampsia. Okay. Next is a chronic pre-existing hypertension. Chronic pre-existing hypertension. In such case, defined by the blood pressure more than or equal to 140/90 millimeter of Hg, and it occurs before 20th week of pregnancy. Even before the 20th week of pregnancy, there is pre-existing. But chronic hypertension with superimposed preeclampsia. This is used when a woman with chronic hypertension develops worsening hypertension and new onset proteinuria or other features of preeclampsia as outlined previously. Gestational hypertension more than 140/90 after the 20th week of pregnancy without proteinuria. So how will you treat the patients? The treatment of these patients, it should be begin if a systolic blood pressure more than 160 systolic blood pressure, or diastolic blood pressure more than 1 or equal to 110. In such patient, treatment of hypertension begin. Non-pharmacological therapy such as weight reduction, vigorous exercise is not recommended during pregnancy. So tobacco, alcohol strongly avoid. So the first line therapy is always alpha plus beta blocker, labetalol, then nifedipine. It's a long acting. It's a calcium channel blocker, or methyl dopa. These can be used. These are recommended as first line therapy. Other antihypertensive have theoretical disadvantage, but none except the AC inhibitors have been proven to increase the fetal morbidity and mortality. So all those AC arabis are better avoided. If patient is suspected to having preeclampsia or eclampsia, urgent referral to an obstetrician who specializes in high risk pregnancy is recommended. Okay. Then another is a MAVO inhibitor. So it is MAVO inhibitors used in association with certain drugs or food can produce a catecholamine excess state and accelerated hypotension. So if you're using MAVO inhibitor plus certain foods, so it can accelerate hypertension, that it can cause accelerated hypertension. Can cause accelerated hypertension. So interactions are common with, so what all foods or drugs it can be. So what all drugs? Drugs like TCA, tricyclic antidepressants, miperdine. What is miperdine? Miperdine is an opioid, okay, opioid agonistic drug. Next, methyl dopa, which we treat in pregnancy hypertension, or levodopa, or sympathomimetic agents. Or antihistamines. The tyramine containing food that can lead to this syndrome include cheese. Tyramine containing food is very important in causing the interactions. Tyramine foods like cheese, red wine, beer, chocolate, chicken liver, then broad beans, yeast, etc. The nitroprusside and labetalol and phentolamines have been useful effectively in the treatment of accelerated hypertension associated with the MAVO inhibitor. In such case, we used to treat with the sodium nitroprusside, labetalol, alpha plus beta blockers, then phentolamine treatment. Next topic is complications. You see complications when you're discussing about complication of this hypertension. Should see that withdrawal syndrome associated with the discontinuation of antihypertensive therapy. In a substituting therapy in patients with moderate to severe hypertension, it's reasonable to increase dose of new medication in small increment while tapering the previous medication to avoid excessive BP fluctuations. On occasion, an withdrawal syndrome develops usually within first 24 to 48 hours. Acute withdrawal syndrome, AWS. It occurs first 24 to 48 hours. Occasional BP rises to level that are much higher than those of baseline value. The most severe complications of withdrawal syndrome include encephalopathy. So withdrawal syndrome, the most complication is encephalopathy, stroke, MI, sudden death. Withdrawal syndrome is associated with most commonly with centrally acting adrenergic agents, especially it's associated with centrally acting drugs like clonidine. Also is associated with beta blockers, but has been reported with other agents as well, including diuretics. Okay. Discontinuation of antihypertensive medication should be done with caution in patients with pre-existing cerebrovascular or cardiac disease. Management of withdrawal by a reinstitution of previously administered drug is generally effective. Monitoring your follow-up, that is another topic. BP measurement should be performed on multiple occasions under non-stressful circumstances, especially sitting, rest, empty bladder, comfortable temperature, to obtain an accurate measurement of BP. Hypertension should not be diagnosed on basis of one measurement alone unless it is more than 210 bar 110 or accompanied by target organ damage. So if BP is more than 210 bar, more than or equal to 210 bar 120, we can diagnose hypertension. Otherwise, you require two measurements. Okay, two measurements. Um, Two or more abnormal readings should be obtained, preferably over a period of several weeks before the therapy is considered. Care should also be used to exclude pseudo-hypertension, which usually occurs in elderly individuals with stiff, non-compressible vessels, a palpable artery that presents after cuff inflations. If you see a palpable artery, you see a palpable artery after cuff inflations. After cuff inflation. What the sign called? The sign is called Osler's sign. Osler's sign. Osler sign. Palpable artery that persists after cuff inflation should alert the physician of the possibility of pseudo-hypertension. Home ambulatory BP monitoring are used to assess the patient's true average BP, which correlate better with target organ damage. Circumstances in which ambulatory BP monitoring might be of value included. So that's all about the hypertension treatment. So thank you for listening. Have a nice day.